Dear students, we'll discuss an endoscopy procedure. You know that endoscopy is gastroscopy, colonoscopy, they are very common. Bronchoscopy is there, sometimes enteroscopy is there. Then different cystoscopy is there. There are so many scopies there wherever you want to see visual. Laparoscopy also actually sometimes it is called as evaluation method. Endoscopy are specifically endo. They are usually gastroscopy and colonoscopies are basically endoscopy, of course, bronchoscopy also. So what we commonly consider as a surgeon is gastroscopy and colonoscopy. So what we are discussing today is a colonoscopy procedure. So what this procedure is, just have a look. See that? See that is a colonoscopy view. You can see that proliferative lesion is there here. And here also proliferative lesion is there. See that uveted edge proliferation, ulcers are there, large proliferative lesion in the actual hepatic flexure of the colon. So you can see that this is the transverse colon. This like this cut this part is a transverse colon, and so you can see a polyp here. This is a polyp actually. So this is the proliferative lesion. Proximally there is a polyp in the transverse colon. So this is colonoscopy procedure. It is visualization of large intestine perennially. So what is important in colonoscopy is a preparation. So many times in old people, we will admit the patient. Otherwise, you can ask the patient to take proper preparation. So many preparation methods available are there, like osmotic thing and enema you can give. So bowel should be, large bowel should be empty. So previous day clear fluids. Then you got different preparations are there. Coloprep, PEG like polyethylene glycol, which increases the fluid and patient passes the stool for 10 to 12 times previous day night, and usually these things these should be taken in a fluid, usually around 1 to 2 liter fluid. Patient should take it over the span of 2 hours, not suddenly continue every 10 minutes one glass like that. 2 hours patient has to take, and they'll get a continuous stool formation and stool passage. So 10 12 times when they pass the stool, clear fluid they will pass. When they pass the clear fluid, it's understood that stool is cleared, then you can take colonoscopy. Otherwise, when there is a lot of colon is loaded with the stool, when you do colonoscopy, it will not be able to see properly. So preparation of the bowel, large bowel for colonoscopy is very, very crucial, important. Unless it is prepared properly, you won't be able to do colonoscopy properly or successfully because you won't be able to take the finding. And additionally, either sedation or short GA is important because unlike gastroscopy, only local spray is used, that is acceptable. Where it is very difficult, patient has severe pain. The negotiation to the entire length of 1.5 meters colon is not that easy without any sedation, even though all propofol or short GA. So anesthetic should be there while do the colonoscopy. So in the lateral position, do a parietal examination initially, then negotiate the colonoscopy with the monitor. First thing, most of the 3 areas are difficult to pass through. One is sigmoid colon, second is splenic flexure, third is hepatic flexure. So how to pass through the sigmoid colon is called like this. Sigmoid colon is like this, you know that colon like this, sigmoid. So it is alpha maneuver. That is called as alpha maneuver. Once you reach the descending colon, then you have to pass through the splenic flexure. It is going like this, coming like this. Acute angle is there. This is also again difficult one. Third is hepatic flexure, not that difficult, but that is the third difficult part. Then once you reach the cecum, you can see the opening of the ileocecal junction, you can see the wall. Sometimes you'll be able to see opening of the small opening of the appendix also. Mainly ileocecal wall will be able to see. There is how we will understand that you reach the cecum. Usually it is 120 centimeter or 130 centimeter like that, depending on the status of the individual. Tall individuals will be little larger. Females and start will be smaller. Usually 1.2 to 1.5 meter it is. So passing through, often you have to inflate the balloon, inflate the colon. But through the colonoscopy, you can inflate, like in gastroscopy, it is the same way. Unless you inflate, you won't be able to negotiate. You have to visualize the lumen continuously while passing through that. You need 2 sisters' help also. Anesthetic also should be there. Unless you give sedation, it's difficult. So needs usually around 20 to 30 minutes to pass through that. So alpha maneuver, difficulty in passing the splenic flexure and hepatic flexure, reaching cecum. If you don't reach the cecum, your colonoscopy is incomplete because any finding is there, the cecum may miss it. So entire colonoscopy becomes a failure. So often it is find difficult then to be truthful to the patient that you could not reach the cecum. That is also very important. So many times elderly will admit the patient. Short GA also very useful in this patient while do the colonoscopy, and take multiple biopsies. There is a lesion, take biopsy from the lesion. Like in this patient, there is a growth actually. It's a very proliferative lesion, typically malignancy it is growth. And same thing in other multiple lesions are there, ulcers are there. Then you've got so many indications you can do: ulcerative colitis, Crohn's disease, recurrent diarrhea, multiple polyps, and stricture, carcinoma colon, terminal ileum will be able to see many times, tuberculosis, ILL disease. So many conditions are the indications. They are classified as diagnostic and therapeutic. In therapeutic colonoscopy, in medical gastroenterology do it when they are trained well. They will do stenting, colonoscopic stenting. They will do polypectomy. It's a very common procedure done. And fulguration of the bleeding point also can be done through the colonoscopy. There are so many procedures which we can do. That's a therapeutic method through colonoscopy also. So that's it classified diagnostic and therapeutic indications. And complications, perforation. Either you can perforate the splenic flexure also, you can perforate the sigmoid also. Then you will scope enter the peritoneal cavity. You can see the small bowel. Immediately you understand that they have done the mistake, there is a complication. Then you know they got no other option. You have to do a laparotomy and close the perforation and come out. So don't think that it will seal on its own. It will not. You have to go ahead and do the laparotomy and close the perforation with the silk or vicryl and identify the perforation. So because most of the time don't require a diversion in this patient because already it's a prepared bowel, but identifying and doing a laparotomy is important. Usually in such situation, do an X-ray, gas and diaphragm is there. Plain CT definitely helps in diagnosing the complication. Hemorrhage can occur. So contraindication is acute colitis and acute ulcerative colitis because very friable colon. It may perforate it. So in such situation, don't do it once everything settled on acute episode. Then you can do the colonoscopy later. So you can always read my manual of surgery colon chapter or rectum chapter for detail about the colonoscopy. So students read my SRB manual of surgery. Also read my SRB clinical method of surgery. Again, I am requesting subscribe my YouTube channel, like it, and also share with your friends and colleagues. And for daily lectures for 5 to 10 minutes, it will upgrade your surgical knowledge. Daily small beautiful topics will be discussed with the mainly clinical cases, images, X-rays, operative procedure, and endoscopies and case discussions. It will be very interesting and very useful. And also once in regular intervals, maybe once a week or 2 weeks, we'll have a live session with the interactive session with the students who will present the case, so that you can put in the chat box and give their answers from the senior professor other than me. So that a live session will be very useful for facing your exam, practical exam, 1.5 hour lecture. So very good. So that will be useful, and you'll get those who will join live session will get a certificate which will be very useful for your future career. So that's why I request everybody to subscribe my YouTube channel and regularly go through the YouTube channel to upgrade your surgical knowledge. And do not forget to join the live session whenever it is there at regular interval basis. So students, I hope this is the MCQ. Let's see humans biopsy forces used for ABCD. Find out the right answer. I'll acknowledge your answer. Second MCQ is most commonly associated cancer with the FAP, familial adenomatous polyposis, is carcinoma stomach, hepatocellular carcinoma, periapical carcinoma, carcinoma ovary. Put the right answer. I'll acknowledge your answer, students. And quotation of the day: speak in such a way that others love to listen to you. Listen in such a way that others love to speak to you. So both speaking and listening, both are equally important when you have a proper communication. Otherwise, if you don't have these two basic qualities, you won't be able to have a proper communication method. Listening, speaking, both are the proper. If you are proper with these two things, your communication with anybody will be perfect. That's what exactly meaning of this quotation. So again, request students subscribe my YouTube channel, join regularly for live session. So students, I hope you understood this lecture very well. Thank you so much.